down for us in New South Wales. So I hope this is a bit of entertainment for you. So we're very privileged to have Professor Stephen Donn from Michigan to speak to us today. So I am bribing him with lots of virtual coffee because it's very late over where he is. But he will talk to us about a huge, therapeutic dilemma in the neonatal ICU. Shall we use volume or pressure guarantee ventilation, or volume guarantee or pressure ventilation for little babies? He has given us permission to record this talk and to distribute the link afterwards. Just a little, some housekeeping rules. We will mute you on entry, and if you have a really burning question for Steve, just raise your hand with the little icon on the bottom, or type your questions on the chat pane for him to answer at the end. We'll post a link for the talk on our social media pages as well as our UNSW website in due course. And at the end, if you have any questions, I'll put Dr. Donn's email address as well on the chat pane for him to answer if we run out of time. So without much further ado, and lots of coffee coming your way, Steve, over to you. Thank you.
Thank you, Julie. And again, other than the hour, it's a pleasure to be with you. And this is a subject that's very near and dear to my heart, and I spent much of my career trying to answer the question, which is better, volume or pressure? And I come to the conclusion that there are indeed fundamental differences, that, again, it's more than just Coke versus Pepsi. So my first disclosure is I prefer Pepsi. Here are my disclosures and conflicts of interest. And my objective for the next hour is to, number one, try to define the pulmonary injury sequence. Number two, I will try to get you to understand the differences between pressure-targeted and volume-targeted breaths. And finally, we'll review the clinical evidence. This is a slide that, of course, is not unfamiliar to anybody who's been in a neonatal intensive care unit. This preterm baby has respiratory failure secondary to prematurity and respiratory distress syndrome, and has been intubated and placed on a mechanical ventilator. The question now is, what ventilator settings are we going to use? And should we focus on a volume-targeted breath or conversely on a pressure-targeted breath? And I think it would be best if we started with understanding the concept of ventilator-induced lung injury, or villi. And on this slide, you see the list of traumas that have been implicated in causing lung injury: barotrauma, which is trauma from pressure; volume trauma, trauma from volume; atelectotrauma, a term coined by my good friend Reese Clark, refers to the collapse of alveoli and the repetitive opening and closing; biotrauma, which refers to both infectious and inflammatory injury brought about through the lung; and finally, rheotrauma. This is a term that I coined a number of years ago because there is indeed problems related to flow, or how gas is delivered to the lung. If it's too high, it creates turbulence and inadvertent PEEP. If it's too low, it may lead to atelectotrauma and inadequate volume delivery, resulting in air hunger. And it's understanding the interactions of these forces and how they result in damage at the level of the alveolus. Now, here's a little schematic to try to demonstrate that. if this is our model alveolus with the proper degree of inflation, we can define volume trauma as overdistension of that normally aerated alveoli from excessive volume delivery. You can see what happens. It gets overdistended and causes loss of integrity of the epithelial membranes. The converse of this is atelectotrauma. And again, you can see what happens. The alveolus collapses to a fraction of its normal size. And then the repetitive opening and closing of this under-recruited alveolus again results in loss of integrity and damage to the cell and surrounding tissues. The question has been around for a long time, and what is it? Is it volume or is it pressure that actually causes injury to the lung? And there were a couple of pretty famous experiments done back in the late 1980s and 1990s, first by Hernandez and then by Dreyfus, in which they demonstrated severe acute lung injury that occurred in small animals when large tidal volumes were delivered. They then showed that if you bound the chest cavity and exposed the lungs to high pressure, the acute lung injury markers were much lower than the injury that ensued once the binding was removed. And the binding obviously was a way of limiting the amount of volume that could be delivered to those lungs. And what they concluded was it was really excessive volume and not high pressure that's primarily responsible for lung injury. And this is what their little experiment looked like. A large tidal volume injected into this animal with a strapped chest doesn't hurt the lungs, even if the peak inspiratory pressure that's delivered is quite high. But if you push that same tidal volume into the lung without the animals having the strap around the chest, it causes the lungs to burst from excessive volume delivery. And that happens even if the peak inspiratory pressure is not very high. Now, I think that over the years, we've done a little bit better job of unraveling the pulmonary injury sequence and finding ways to help reduce either the severity or the incidence of chronic lung problems. And I'm going to start with this little tabular slide, which shows the lung development phases. And you all can remember back to your days in medical school when you studied embryology. We know that the lung goes through a series of developmental phases, beginning with the embryonic phase that lasts for the first 5 to 7 weeks, followed by the glandular phase, 16 to 17 weeks. Then we enter the canalicular phase up to 24, 25, maybe 26 weeks. And it isn't until the baby gets close to and then beyond term gestation that septation and alveolarization take place. And over the first couple of years, that's accompanied by maturation of the lung's microvasculature. So if we end up having to deliver a baby at the extreme edges of viable premature birth, you can see that that baby is really in a very immature state of lung development. The baby may be in the canalicular or the saccular phase of lung development, where both the number and the maturity of alveoli is exceedingly low. And what happens then is these babies are born with inadequate lung function, and this forces us to initiate chronic ventilation. Now, when we ventilate these babies, we all are aware that the qualities of their premature lungs are going to increase the susceptibility to ventilator-induced lung injury. They're born with surfactant deficiency. Well, over the years, we've done a pretty good job of repleting them, although I worry about abbreviated techniques and return to non-invasive ventilation that may deprive some babies of surfactant when they really need it. These babies are also characterized by premature antioxidant systems, so they are at risk for oxidant injury. The very gas that's necessary to keep them alive becomes a double-edged sword. They have premature lung structure. We talked a little bit about that, but again, that subjects them to injury at lower levels than if they were full-term and more highly developed. And a final factor that we often don't pay enough attention to is a compliant chest wall. And for these babies, the chest wall is more compliant than the lung and therefore increases the work of breathing. And all of these things will transpire to produce what we've labeled as ventilator-induced lung injury. But that's not the only pathway through which injury occurs. This is what I like to refer to as the intrinsic pathway. We can start at the bottom here. Again, we know that oxygen is toxic to tissues. Even adults breathing 40% oxygen will show signs of toxicity after only a few hours. Babies are exposed to lung and systemic infections, which again contribute to biotrauma. We fight a never-ending battle each day with trying to get adequate calories into these babies in order to get them to grow. And after all, it's growth that will enable them to overcome some of the lung injury. Glucocorticoid treatment, either given antenatally to the mom or postnatally to the baby. And this is really another one of those good news, bad news drugs. Yes, it reduces inflammation. Yes, it helps the babies. But on the other hand, glucocorticoids are very potent inhibitors of protein synthesis. And therefore, again, in our battle to try to get these babies to grow normal lung tissue, steroids may actually be a downside. And finally, intrauterine cytokine exposure. This may be the whole linchpin for BPD, and it may also have been the element that brought the baby to the nursery in a premature state from chorioamnionitis and fetal inflammatory response syndrome. So all of these things, both the ventilator-induced lung injury and this intrinsic pathway, have a combined effect of inhibiting alveolarization and leading to the development of chronic lung disease or bronchopulmonary dysplasia. And this was very nicely pointed out by Alan Jobe when he coined the term the new BPD about a dozen years ago. So that leaves us in a very interesting situation. And again, during the course of my career, I've seen the pendulum go back and forth between physicians who believed that pressure targeting was the best way to go because it was the best way to avoid barotrauma. And then the pendulum kind of swung towards volume targeting. Don't worry about the pressure, worry more about the volume. And you saw evidence for that a little bit earlier with the Henderson and Dreyfus experiments. Now, this is probably the most important slide that I've included in the lecture because it shows you the differences between volume targeted and pressure targeted breaths. And let's start on the right side of the slide in red, the typical pressure limited or pressure controlled breath. And what happens when the breath begins is that there is a rapid acceleration of inspiratory flow, which peaks very early in inspiration, then rapidly decelerates back to the baseline. And what this does is it creates the so-called shark fin pressure waveform. And you'll note that peak pressure and peak volume delivery occur very early in inspiration. So I like to refer to this as a front-end loaded breath, meaning that you get most of the pressure and volume delivery occurring early in inspiration. Now, intuitively, when should this afford an advantage to a baby with respiratory disease? Well, number one, it would be if the baby has homogeneous lung disease that has the need for high opening pressure. And when does that happen? Well, it probably happens only for the first few breaths. And beyond that, the baby then develops alternating areas of atelectasis and hyperinflation. There's a real heterogeneity of lung disease. And in that situation, if you're using a pressure targeted breath like pressure control or pressure support, what's going to happen is the flow pattern is going to dictate that gas delivery goes to the more compliant areas of the lung at the expense of the lesser compliant areas of the lung. So we actually will contribute to ventilation perfusion mismatch and to heterogeneity of lung disease. Let's shift a little bit now, go to the left side here and talk about volume breaths. And here, I'm not talking about volume guarantee, I'm talking about true volume controlled ventilation, where the flow pattern is the so-called square wave. And what happens when the breath begins is there is a slight acceleration to a peak inspiratory flow level that is then held constant for the entire duration of inspiration until the exhalation valve opens and the breath is discharged. And what this does then is it results in a more slowly ramping pressure and volume delivery, such that peak pressure and peak volume delivery occurs at the end of the breath, at the end of inspiration. And the net effect here then is we have really a slower, kinder, gentler delivery of airway flow, such that you're more likely to have more uniform inflation of the lung than you would if you were using this type of accelerating, decelerating flow waveform. When we look at the functional differences between pressure and volume targeting, depending on our control variable, this is a very interesting concept that we need to keep in mind. And that is, you can control one and the other will be variable, or vice versa, you can control the other and the other variable will be variable. So in other words, here is our index breath during the pressure targeting. And you can see here that we are going to achieve a certain delivery of volume at a set pressure, depending upon the compliance of the lung. So if the lung is really stiff and we apply the same degree of pressure, we're not going to get as much volume delivery as if the lung were more compliant. And this is what happens if you keep the pressure constant and you change the compliance. So the green loop represents what might happen after the administration of surfactant. And now at the same pressure, we're delivering quite a bit more volume. The converse is also true. So if the green breath were our index breath and the baby suddenly developed a diminished compliance, maybe a pneumothorax, maybe pulmonary edema, anything that limits compliance, at the same degree of delivered pressure, we're now going to deliver a lot less volume to that baby. Volume targeting works in a converse manner. So if this is our index breath, here you see a degree of volume that's being delivered at a certain pressure. And if the compliance improves and we're volume targeting, we no longer need as much pressure to deliver the same volume. So the ventilator will automatically wean the peak inspiratory pressure to deliver the desired tidal volume. And again, conversely, in the face of altered compliance, in order to deliver the desired tidal volume, the ventilator will automatically increase the pressure in order to achieve that volume. This is a little bit of a historical background, and that is, this isn't the first rodeo that has involved volume ventilation. In fact, when I was a pediatric resident, one of the ventilators that I learned how to use in order to ventilate babies was the Bourne's LS-104-150. And this device was the first volume targeted ventilator that was specifically designed for neonatal use. And this is a very old slide because it dates back to the mid 1970s. And this is the Bourne's LS-104 ventilator. And it was used in combination with the blender that was produced. Now, this particular ventilator was a 1976 model. And the reason I can tell you that is the Bourne's company, as their logo, often used two-tone green equipment, dark green and light green. But in honor of the American bicentennial of our independence, they came out with a very special red, white, and blue model. So this is a 1976 slide of a typical situation. Now, this ventilator was one of the most polarizing devices in neonatal intensive care. People either loved it or they hated it. And the typical situation was you would be managing a baby on the Baby Bird or the BP200 ventilator, both time cycle pressure limited devices. The baby would continue to deteriorate. You would raise the amount of pressure on the ventilator. And when you reached about 40 centimeters of pressure and it looked like the baby was not going to improve, either the neonatologist or the neonatal fellow would say, you know, maybe we ought to try that volume ventilator. That volume ventilator was in the supply closet, heavily guarded by the respiratory therapist or by the nurse. And when somebody said, let's try the Bourne's ventilator, there'd be a mad rush to that supply cabinet. And depending who got there first, it was either used or not used. And often what happened was we would put the baby on this ventilator. The baby would continue down that inexorable journey towards death, and he would die. And the neonatologist, well, the nurse would say, you see, that machine kills babies. And the neonatologist would say, gee, I wished I'd used it sooner. So it had a lot of problems, limitations. Number one, compressible volume loss. The circuits were very poorly designed in those days. They were nothing more than corrugated cardboard covered by a rubber coating. So they were super compliant. Well, you can imagine what would happen if you discharged a high pressure breath from the ventilator. You'd watch the ventilator circuit billow beautifully, but the baby's chest wouldn't rise at all. The device had a very slow response time, often resulted in dysynchrony. By today's standards, it had a very limited rate capability. It also had a major drawback in that we had extreme difficulty in measuring small tidal volumes. We didn't have today's wonderful transducers. The Bourne's company, I think, was cognizant of this. And they provided us with a bedside computer. See, it says computer. And this is how we estimated the amount of volume that we were giving the baby. What it did was it would help you to calculate compressible volume loss in the circuit, and then subtracting that from what you thought you were giving the baby gave you a very crude estimate of the amount of tidal volume that the baby was actually receiving. It was incompatible with continuous flow, so that in between breaths, the baby wasn't getting any help from the bias circuit. There was a bias among many healthcare providers that although this was a volume targeted or a volume limited device, it created very high pressures and therefore resulted in barotrauma. And of course, we know now that it wasn't the ventilator, it was us, it was the users. We really had no idea what we were doing. We had a lot of mistaken concepts of ventilation, one of which was that tidal volume was proportional to birth weight, that all babies had a tidal volume of about 8 to 10 milliliters per kilogram. So you can imagine what would happen when this device was placed on a 1,500 gram baby, who was then given 15 mLs of tidal volume, and we were overventilating and inadvertently causing a great deal of lung injury. So for all of those reasons, the ventilator was primarily in use through 1977 and 1982, give or take a year on either side, but it fell into disfavor and the manufacturer stopped making it. And by the early 1980s, you maybe could find one or two as a relic in some of the larger neonatal intensive care units in the United States. Well, what changed things? And I can sum it up by saying the development of microprocessor-based ventilation really changed the entire landscape of neonatal mechanical ventilation. Now, for those of you who are like me and not engineering or computer savvy, this is a computer chip, microchip, which nowadays is in very short supply worldwide. But this is magnified several thousand times to show you what it looks like. And once this was inserted into the ventilator mechanism, as we say, it changed everything. Now, this is a very complex slide, and I'm not going through it. I only put it up for one reason, and that's to show you, if you look at this middle panel, this shows you what we can now accomplish with mechanical ventilation using microprocessor-based technology. It's no longer you get one waveform and you're stuck with it. You can alter the pressure waveform, you can change the volume waveform, and look at the number of different ways that we can deliver flow to the baby. So what this tells us is ventilation can now be customized. It can now be individualized to the pathophysiology of the individual patient or the individual patient population that we serve. Along with this came the development of sophisticated transducers, and these allowed us to, number one, actually measure the amount of volume that we were delivering to the proximal airway. It enabled sensitive triggering. These transducers are both lightweight and low dead space, perfect for a neonatal patient because they don't place undue weight on the endotracheal tube and they don't appreciably increase dead space. And combined with real-time data displays, we have enhanced monitoring and feedback and presumably improved patient safety. And again, most of you are using ventilators now that have either built-in or stand beside real-time data displays, similar to this one, which was on the Avia ventilator. And this really gives us a tremendous amount of information. We can talk about, I could give a whole hour on graphics. Maybe we can do that in the future, but basically we look at the waveforms for pressure, flow, and volume. It will even differentiate machine breaths from baby breaths. It will give us readouts on a breath-to-breath basis and really change the whole concept of observing babies on mechanical ventilation. Now, let's talk a little bit about different volume-targeted modalities. For the most part, I'm going to be speaking about volume-limited ventilation. And volume-limited ventilation refers to square wave volume ventilation, where we choose a delivered tidal volume. We allow the pressure to fluctuate to deliver that tidal volume. And the inspiratory time is controlled by the flow rate that we set on the ventilator. There are hybrid modalities of volume targeting. Volume guarantee, I think this is probably the most popular and most utilized. There is pressure regulated volume control, and there is volume assured pressure support. Now, what all of these have in common is they're targeting a specific tidal volume to be delivered to the baby. But what's different is that they don't use this square wave flow pattern. They use an accelerating, decelerating pattern that is similar to pressure control or pressure support. And finally, there is traditional ventilation with close tidal volume monitoring. And over the years, I've often been asked the question, well, we don't have a volume monitor, we don't have a volume targeted device. What if we just used our time cycle pressure limited ventilator and paid really close attention to the delivered tidal volume and adjusted accordingly? Well, I think you should be doing that anyway, no matter what type of ventilation you're providing. The problem with it, though, is that you cannot adjust as quickly as a computer. And you're also making your adjustments post facto after the breath has been given. So it really is not a very satisfactory way of delivering volume targeted ventilation. And this just shows you a volume delivery and assist control. Again, we're looking at this square flow waveform and the delivery of tidal volume. And remember, with assist control, each time the patient meets the trigger threshold, there is going to be the delivery of a mechanical breath that is timed to synchronize with the baby's own breathing. And here you see a typical combination. These two breaths are rather close together, and these two breaths are further apart. Again, showing you the variability in the baby's own spontaneous breathing and how the ventilator will follow that pattern of breathing. So let's take a look at the evidence. And this also has been a very fantastic journey for me. I began this with my close colleague and friend, Sunil Sinha, back in 1994 or 1995. And we had been using volume targeted ventilation in my unit at the University of Michigan. So when it came time to thinking about doing a randomized controlled trial, we had to do this in Professor Sinha's unit because we had lost all equipoise at the University of Michigan, having been convinced that volume targeting was really a much better way to go. So we designed a randomized trial of volume controlled versus time cycle pressure limited ventilation in preterm infants with RDS. And this was a small single center trial. Our study population consisted of preterm infants with RDS who weighed more than 1,250 grams at birth. There were 50 patients placed in this study, half received volume, half received pressure. And the results of this trial were that volume targeting reduced the duration of ventilation, and there were fewer complications, less pneumothorax, less BPD, and surprisingly, something we didn't expect, many fewer severe neurologic complications, grades 3 or 4 IVH or PVL. And we published this in Archives in 1997. And interestingly, we got a lot of negative feedback. People said to us, well, that's all well and good, but look at the population you studied. Babies greater than 1,250 grams really aren't much of a problem. And you really should have focused on smaller babies. And I accepted all that, except for the problem that we couldn't do smaller babies with the technology that was present at the time in the VIP bird ventilator, because the minimal tidal volume that was leaving the ventilator was 20 mLs. It was actually not intended for use in the neonatal population, but rather the pediatric population. So with 20 mLs leaving the ventilator, even correcting for circuit compliance, it meant that the minimal tidal volume that we could get to the proximal airway was 10 milliliters. And, you know, again, unless the baby has really, really stiff lungs and you're watching very, very carefully, you can't ventilate a baby less than 1,250 grams safely. So that's why we focused on the larger babies. Now, in 2005, the first meta-analysis was performed by the group in Melbourne. And again, there were really only 2 studies that had been published at that time. Our study in 1997 and Gianluca Lista's study using volume guarantee in 2004. And yet, it kind of interesting, even though the numbers are very small, if you look at this figure, which shows the duration of intermittent positive pressure ventilation in days, you see that there was already a statistically significant reduction in the number of ventilator days for babies who were ventilated using volume targeting. The incidence of pneumothorax, this included 2 additional studies. A study by Marty Kessler with volume guarantee was added to the volume guarantee, and Professor Piotrowski from Poznan in Poland did a study using PRBC. So with all of these studies, although the 95% confidence intervals are fairly wide, it still reached statistically significant reduction in pneumothorax for babies that were volume ventilated. And this was BPD, defined as oxygen requirement at 36 weeks post-menstrual age. Didn't quite reach statistical significance, crossing the line of unity by 1.05. But nevertheless, we were quite pleased to see that the results that we found in that original study were confirmed by additional investigators. And again, keeping with our observation in the first trial, looking at severe IVH defined as grade 3 or grade 4, there was a statistically significant reduction in severe IVH. So again, we were very pleased to see replication of our study. Well, the technology over the years continued to improve, and in 2006, nearly 10 years after the original trial, we went back and repeated the study that we had done in the larger babies, now focusing on a population of smaller babies, looking again at volume targeted ventilation, a randomized controlled trial. And this was done in primarily James Cook University Hospital in Durham, and there were some additional babies added from Hope Hospital in Manchester in the UK. And the objective of this study was to assess the safety and efficacy of volume-controlled ventilation in very preterm infants with RDS. Now, what we did in this trial was also a little bit novel in that we did not use extubation as an endpoint for the study. And I think that over the course of doing clinical research, you realize that extubation is not a good endpoint for a couple of reasons. Number one, how many times does a baby reach extubatable settings? Maybe it's 2 o'clock in the morning and the person on call says, I'm not going to extubate this baby until the team is here at 8 o'clock. Or what happens for a baby who self-extubates and is doing well, but hasn't met study criteria for extubation. So for all of these reasons, we decided that rather than using extubation, we would use predetermined success criteria, which we defined as a mean airway pressure of less than 8 centimeters of water, maintained for 12 hours, or an alveolar arterial oxygen gradient of less than 100 torr, again, maintained for 12 hours. And we looked at secondary outcome measures as well: total duration of ventilation, survival to discharge, and complications of prematurity and ventilation. And one other thing we did for this study was to a priori stratify it at above or below 1,000 grams birth weight. So we were going to cohort babies based on their birth weight. Our ventilation protocol, we used the VIP Gold infant pediatric ventilator, initially an assist control, targeting an exhale tidal volume of 4 to 6 milliliters per kilogram. Once the babies were reached weaning criteria, the weaning mode that was chosen was SIMV with pressure support. All of the babies were given caffeine citrate before extubation, and they were extubated to nasal CPAP using the infant flow driver. This slide lists the demographics for the study. There were 90 patients in this study, nearly equally divided between volume control and time cycle pressure limited ventilation. No statistically significant differences here. Birth weights, gestational ages, gender, use of antenatal steroids, multifetal gestations, intubated at birth, crib scores, or the oxygenation index at the time the babies were enrolled in the study. This was the primary outcome measure. Again, the time to reaching the success criteria, and the volume control arm is going to be in green on all of these studies, the pressure limited in orange. So for all of these patients combined, although there was a quicker time to endpoint using volume ventilation, the hazard ratios didn't quite reach statistically significant numbers. However, when we looked at the smaller group of babies, those who were between 600 and 1,000 grams, the ones most likely to develop lung injury and chronic lung disease, we reached a very significant difference in the time to achieve the endpoint. These are interpreted very much like Kaplan-Meier plots. You look at the time to the 50% range, and you can see here that it was much shorter in the babies who were assigned to volume control. We also looked at the sicker babies, those who had an initial alveolar arterial oxygen gradient greater than 100 torr. And again, the sicker babies were much more likely to reach the endpoint more rapidly than the pressure limited arm in the study. And the hazard ratio, again, was statistically significant at 0.03. The other outcome measures that we looked at included the duration of ventilation, looking at the mean and the 95% confidence intervals. You can see the odds ratios didn't quite reach statistical significance, but if you look at the mean numbers, this is really a 2-day difference in coming off the ventilator. And mortality almost reached statistical significance at 0.06, even though the numbers are so small. 3 babies died of the 46 treated with volume ventilation, 9 babies in the pressure limited group. And I'll come back to this in a minute. We looked at other complications of prematurity, the types of things that are always cropping up in ventilation studies. And again, I think here we're probably hampered more by small sample sizes than by anything else. Incidence of chronic lung disease, the same. Survival without chronic lung disease, favor but not statistically significant for volume. Pneumothorax, Again, much less with volume. The numbers of babies who required high frequency rescue was greater in the pressure group. Again, severe IVH or PVL, less in the volume group, less NEC, Bell stage 2 or more, and slightly higher threshold ROP, but again, the numbers are so small that it didn't come close to reaching statistical significance. Now, as a follow-up to this, and I need to take about a 10-second break because my dogs are outside barking and I need to bring them in. Unfortunately, we haven't come up with a Zoom button that says mute the dog. So again, as part of this second volume trial that we did in England, we decided to do something that was also novel, which was to try to follow these babies for a period of time longer than discharge from the NICU. And so we designed a follow-up trial or a follow-up observation to follow the babies that had been enrolled in this trial. And the aims here were to compare 1-year survivals, subsequent hospitalizations, pulmonary outcomes, and gross neurodevelopmental outcomes. And the methods that were used here included a structured questionnaire that was part of a parental interview where the interviewer was unaware of the allocated modality of treatment, a review of the hospital records, follow-up assessments by the pediatricians, and this was validated from the SELECT and STAR trials of Moya and Sinha, published in Pediatrics in 2007 after the lucinactant surfactant trials. The respiratory outcomes that we were most interested in were the frequency of cough and wheezing, the need for pharmacologic agents, and hospital admissions, whether they were for respiratory or other reasons. And this is the ascertainment flow diagram. You can see we initially had 109 babies recruited, 94 surviving to discharge, 3 dying after discharge, and therefore 91 babies eligible for follow-up. And of those, the health status ascertainment was completed in 93% of the babies, or 85 of those 91. And I give all the credit for this to my good friend Win Tin. Many of you probably have either know him or know of him from the CAP trial and the incredible job he does with neonatal follow-up. So overall, the mortality at follow-up is shown on this slide. Volume controlled 5 of 46 or 11% compared to 10 of 44 in the pressure group or 22%. Now I showed you there was a difference in the neonatal period. Here is the Kaplan-Meier plot for the two groups taken out as far as 800 days of life. And although this difference, again, did not reach statistical significance, it's pretty impressive given the overall low rate of mortality that most of it was seen in the TCPL group. But again, most of the difference is seen early on while the babies were still in the neonatal intensive care unit. This slide lists the respiratory outcomes, and you can see that both wheezing and the use of an inhaler were significantly more common in the babies who were treated with pressure-targeted ventilation and less common in those who were treated with volume. So we concluded after having done the two randomized trials and the 1-year observational follow-up, that volume controlled ventilation was safe and efficacious in very low birth weight infants. The trend towards decreased chronic lung disease at 36 weeks, corrected gestational age, indeed had a clinical correlate at follow-up with less wheezing and less need for inhaled bronchodilators, and suggested at this time that a larger study comparing clinically relevant outcomes appeared to be indicated. So the question is, where are we with respect to volume targeted ventilation? And I'll show you now the evolution of systematic reviews that occurred over the course of time as more and more volume targeted studies appeared in the medical literature. Here is actually the personal communication that Peter Davis shared with me, knowing I'd be so excited to see it. Again, this was done in around 2006, 2007. Again, not too many studies or patients, but again, that statistically significant difference in a less duration of intermittent positive pressure ventilation. Pneumothorax, again, more studies added, and again, statistically significant reduction in pneumothorax if you were volume ventilated. Chronic lung disease didn't quite reach statistically significant difference as of 2007, but I think we were certainly well on our way. This was from a later meta-analysis in 2010. And here again, now we have 20 randomized controlled trials, 9 parallel trials with 629 infants, 3 crossover trials using or utilizing 64 subjects. And you can see that pneumothorax, grade 3 and 4 IVH or PVL, hypocarbia, and days of mechanical ventilation were all statistically significantly favored by volume targeted ventilation. Death or BPD, again, not quite there. But what these authors concluded was that infants ventilated using volume targeted ventilation modes had reduced death and BPD compared with infants ventilated using pressure limited ventilation modes. Again, they recommended further studies needed to identify whether these modes improve neurodevelopmental outcomes and to compare and refine strategies of volume targeting. This is a subset of that. 2011. Pneumothorax again. IVH, grades 3 or 4, statistically reduced. And this is from a meta-analysis that was done by Peng and colleagues in 2014. And you can see now that there are more than 700 patients have been entered into the studies they examined. Here are our 2 studies. And again, not quite statistically significant mortality with the 95% confidence interval crossing the line of unity. But we look at BPD, again, about a 39% reduction in volume targeting compared to pressure limited ventilation. Duration of ventilation, again, volume targeting reducing the incidence of BPD, the duration of mechanical ventilation, the failure of primarily assigned ventilatory modes, grades 3 and 4 IVH or PVL, and air leaks compared to pressure limited ventilation. Now, I just sort of have to pat ourselves on the back because, again, despite the criticism, these were the exact findings that we published in 1997 in our first trial in the 1,250 gram or greater babies. And the latest Cochrane review, published in 2017 by Klaus Klingenberg from Tromsø, Norway. Again, fewer air leaks, shorter duration of ventilation, improved survival, and less BPD in babies who were ventilated using volume targeting compared to pressure targeting. So the question then is, I showed you the theoretical basis. Can we find any evidence that helps to support the superiority of volume targeting? And the answer to that is yes. This was yet another spin-off of the second volume trial that we did in Middlesbrough and Manchester. This was published by Ravi Shankar, who was doing this spin-off project as his doctoral thesis. And what he was able to do was, using a sophisticated software package, he had a data tracker that was able to record every breath delivered to every patient that was in this trial. And what this slide demonstrates are the median tidal volumes that were measured in each of the two trial arms. So here you see the volume control arm, and here the pressure targeted arm. And you can see that we did a really good job. Remember that I told you that we had targeted exhaled tidal volumes. We were able to hit this spot on with both groups. Again, the median tidal volumes. But when we look at variability of tidal volume, you can see that those babies who were assigned to volume controlled ventilation had a much tighter cluster of delivered tidal volumes compared to those who were in the time cycle pressure limited group, where the interquartiles go up to 3 standard deviations from the desired mean. So I think that one of the things this taught us is that, again, there is much more uniform tidal volume delivery with volume controlled ventilation, and you're much likely to avoid these scenarios where you're getting much too high a pressure delivered. Now, this is from an adult study. I'm not certain how much relevance it has to the neonatal population, but it's certainly of interest. In adults, you can do more measurements, and you can actually measure work of breathing and express it as joules per liter. And what you want here is a low number, indicating that there's a lower work of breathing. And you can see that it was the lowest with volume controlled ventilation, higher for pressure controlled ventilation, and highest yet for pressure regulated volume control. So maybe, again, in babies, the work of breathing is perhaps lower with volume targeting. So that brings me to my conclusion slides. And I think that volume targeting, number one, leads to a small but clinically important improvement in short-term pulmonary outcomes, including chronic lung disease. I think the next step is to better understand and refine the technique and to measure important outcomes in infancy. I really hope we're going to be able to recapture some of these patients when they get to adolescence, to see whether or not there are long-term implications in pulmonary function. It's not funded and it's not part of our study, but we're still working at it. However, let me close with one caveat, and that is, thus far, all the systematic reviews that I showed you have aggravated all forms of volume targeting. So we don't know at this point whether there are clinically significant differences between volume control, volume guarantee, PRVC, or other means of volume targeting. Those will still have to be derived. But in the meantime, since all modes of volume targeting seem to be better than pressure targeting, I think our goal should be to control the volume. And with that, I will stop and be happy to address questions if we have time.
Excellent. Thank you, Stephen. Beautiful slides. And yeah, Coca-Cola is on its way. Right. While we're waiting, oh yes, thank you, Dr. Donn. There's a question here from NTT. Sorry, don't know your name. Please share your opinion on VG plus HFOV in low birth weight infants. Could you comment on that?
I can comment to the extent that I have no experience with it because the device has not been approved by our Food and Drug Administration for use in the United States. But certainly the literature suggests that in the right hands, it's a very good tool. I think the oscillatory mode is good for smaller babies. I don't think it has the power of the SensorMedics device. And there's probably a weight limit of 1,000 or 1,200 grams where it begins to lose its efficiency. But in the right hands, somebody like Manuel Sanchez Luna, it's a wonderful device.
So the States does not use HFOV at all, VG plus HFOV at all.
Correct.
Wow. Okay. Right. Maybe next talk. Okay. So if we have a clinical trial to look at it, mortality as an outcome, we'll need 1,300 babies.
Yeah, we'll need a lot of babies. unless we restrict it to babies, say between 400 and 600 grams, where the mortality will be higher. But yeah, it's a numbers game.
What are your barriers to doing such a trial? I mean, it sounds like you have a lot of interest.
The problem is going to be number one, assembling enough numbers. Number two, getting enough investigators. And number three, getting those investigators to agree to a uniform protocol. We haven't done a very good job with that.
Well, if anyone's interested, contact Stephen Donn. Right? You just need about $5 million in funding, US dollars. Okay, there's a question from Jan, Dr. Klimek from Westmead. He asks if you can comment on the delayed differences between different ventilators in achieving a targeted volume, breath to breath or within 5 breaths. Yeah, this is such a complex question. Can you unmute yourself?
Yes, hello.
Hello.
Thank you, Dr. Donn, for a lovely presentation. I can't see myself, but thank you for a lovely presentation. Now, as you know, there are different ventilators and different software algorithms to achieve volume targeting within the different ventilators. Now, those are quite significant in some babies. So some will target breath to breath changes and try to aim for the targeted volume, whereas some will get there very, very slowly within 5 breaths. So that's my first question, whether you can tell, you can spontaneous breaths versus ventilator breaths, whether the algorithms are safe, in your opinion, to measure the different breaths given and then to target volume within these different breaths. Thank you.
Yeah, wonderful question. And there's yet another component to this question is, what about leaks? which really throw the algorithms off. I think you can see how the technology has evolved. If you look at one device, which is the Draeger baby, was commercially available while they were in the development phases. And they said, what do you think of this idea? And they said, you know, we're going to target exhale tidal volume. And the first attempt was using an 8-breath moving average. So they would average 8 breaths and make an adjustment based on the exhale tidal volume average over that period of time. And I said, I think there is a dichotomy, and that is the difference between safety and efficacy. I think that using exhale tidal volume is probably going to be more efficacious, but I think you should target inspired tidal volume to be safe. And they said, well, what do you mean? And I said, well, the problem with exhale tidal volume is we don't use cupped endotracheal tubes, and there's always a variable degree of leak. So if the baby turns his head or flexes his neck, changes the magnitude of the leak, you're going to have a risk of overcompensating when you adjust for the delivered tidal volumes. And it turned out some of the first work that Martin Kessler did with this device was they very severely overventilated babies. They were showing significant reductions in partial pressure of carbon dioxide with the device. And then they moved to a 4-breath moving average, and it got a little bit better. Then they went to a 2-breath. So each time they made the adjustment, I think it got a little bit more accurate. Second point is measurements really have to be done at the proximal airway. You can't use measurements made in the ventilator to calculate compressible volume loss and therefore delivered tidal volume. The group from Duke showed that in babies less than 1,500 grams, there could be a 50% variance from measuring it at the proximal airway. And I think most of us would agree with that. So I think with those things in mind, one of the keys is to know the machine you're using, knowing how it's calculating these values, knowing how to troubleshoot it, knowing when things aren't exactly the way they're supposed to be. And part of this, again, is the concept of endotracheal tube leak, because until we have an effective cupped endotracheal tube, that's going to preclude us from probably having 100% accurate tidal volume measurement. I hope that answers your question. It was kind of roundabout.
Okay, happy, Jen? Jan, happy?
Yes, thank you. This is a very complex question and ongoing issues, but thank you very much.
Yes, we have kids with really high leaks on our tubes, 80-90%. Oh. Okay. Any other questions from anyone else? So unfortunately, I can't read Chinese. There's something from Hunan in Chinese. So if you want to translate, that'll be great. But otherwise, Dr. Donn's happy to take email questions. I
In
guess
English.
in English. Oh, I thought your Mandarin was superb. Okay. All right. So if there are no more questions, we are way past the hour, 10 past 1, and very late for you, Dr. Donn. So I'd like for you guys to join me in thanking Dr. Donn again for this superb lecture. And maybe he'll come back and talk about, what, some other time. What is your next ventilatory niche?
Well, we could do graphics. We could do my 10 commandments of mechanical ventilation.
That would be amazing. The 10 commandments of mechanical ventilation. That'd be great. So we'll book you for the next time. Maybe
My pleasure.
another time. Yeah.
And I'll put it on your coffee tab.
When lockdown finishes, I'm going to owe you a coffee plantation. All right. Okay. Thank you very much. And all right. Bye, everyone.